If you look at Kenya specifically, Kenya spends about $5 billion on health. Out of that $5 billion, only about $1 billion is from donors, from all these Global Fund, Global Vaccine Alliance, US government and others. $4 billion is a contribution of the taxes of the people and the people from their pockets, what we call out-of-pocket expenditure. It is people who have a patient in the hospital and then they have to actually fundraise or sell their land or something. That comes to maybe about $1.5 billion. And the balance of it is the county and national government. So 80% is from us. So when you have withdrawal of development assistance, the question is not about that there is no more financing. It is that there were certain programs that these donors were funding, which was vertical. And the majority of that money, which is $1 billion, which is where the change is happening, out of the $5 billion, is that they were funding specific programs that are of interest to the donors. That's HIV, tuberculosis, malaria, a bit of maternal health. And it is not to say that this money was not beneficial to the Kenyan people. It was, in fact. Most of the HIV medications for the people, about 1.3 million people, who are people living with HIV in Kenya, their medication on a monthly basis is funded through this money that is being taken away. So it is, of course, a big impact. The question is, how does the government reorganize the $4 billion to ensure that it accurately takes care of the most vulnerable who are being left behind by withdrawal of this money? So it's not a collapse of the health system. It's a question about how we reorganize our existing money, reduce what people are paying out of pocket, increase the cover for the most vulnerable, and make sure that there is social protection so that those people who are receiving these medicines that have been pulled away continue to receive and reorganize the efficiency of the money that actually the government and the people have through better efficiency. That is really the big question that we need to ask ourselves, because it is not charity. It will go. The question is, what is our role in financing health for our own people, which we are already doing? The most critical services that are funded by donors but are now facing the risk because of the withdrawal are medications for people living with HIV. That's really critical because Kenya has about 1.4 million people living with HIV. They need medication for them to be fully participatory in the economy. And that is one thing that the government must do to ensure that these 1.4 million people who are receiving HIV medication from donors are in the budget and continue to receive their medication. That's number one. Number two is tuberculosis. The people who are being treated and tracked to ensure that we reduce the burden of TB, the government must continue to do so. The next one is family planning. There was a lot of family planning support by donors, yet our government and many governments in Africa have kind of left family planning, commodities and care to donors because it's not seen as a critical area of investment. Yet, we know that if we don't actually invest in family planning, then our fertility rate goes high, our adolescents continue to be pregnant. In this country, 25% of girls between 15 to 19 years are pregnant or have been pregnant before or have a child, which is a big challenge to the economic development because they can't go to school. So we must refocus and say these programs which are critical for socio-economic development, the government must budget for them or reallocate money to ensure continuity. So there is a question here then around how we finance our health services across the country. So I would comment on certain things. Number one is that public health financing and public health services are the most critical in ensuring that a country has a healthy population. Focusing on public health provision. Private sector is extremely important, but must be a partner of public health services, not an alternative to public health. Meaning that the public health services should complement where government needs help and should complement delivery of publicly led health services. That means that public facilities should be at the backbone of health service delivery. We know, for example, in this country that the best services in terms of quality actually exist in the public health system. But people believe that the best services are in private sector. If you look at quality assurance, the best quality assurance programs, largely, this is not copy and paste to every facility, but the best quality assurance is actually in public facilities. That's where you find the best cardiologists. That's where you find the best laboratories. That's where you find the best surgeons. And the challenge that we've had is the areas around customer service, compassionate care, overload of the health workforce, continuity and follow-up, patient navigation. And I think this is where the government needs to work on, so that the public can willingly start to shift to sourcing their services from public facilities, because that's actually where the best oversight and the best care is. But we are lacking the side of compassionate care and customer service, which is what needs to be worked on, so that even as we talk about forcing civil servants to use public facilities, it is about asking, what is it we are going to do in the public facilities for us to encourage people from private sector, including our civil servants, to actually use public facilities? And that is possible. So there's no need of having a program for civil service, a program for others. All Kenyans are equal, and what we need to ask is, what is it we need to do to our public services so that every Kenyan feels comfortable to seek their services from there, and the private sector becomes complementary and supplementary to the publicly led health system. The question around whether our healthcare services are aligned and whether our public expenditure is adequate is a question that is related to whether we should focus on health or whether we should focus on health care. There's a difference of night and day. When you focus on health, it means that you recognize that every individual is born healthy. Only about 5% of people are born unhealthy. 95% of people are born healthy. Therefore, focusing on health means that you want to keep the people healthy. Focusing on healthcare means that you want to focus on waiting for when people get sick and treat them. And we cannot afford that kind of approach. That is what we call the biomedical approach to health services. Now, in this country, we cannot afford a healthcare model. And in many African countries, not only in Kenya, you cannot afford a healthcare model, largely because our economies are small relative to our population. I'll give you a key number. Germany, as a country, has a population of 87 million people. Its GDP is $4 trillion. Africa, as a continent, has a population of 1.4 billion people. Its GDP is half that of Germany at $2 trillion. So if you just look at those numbers and population, even if you taxed well, you will not have enough money to take care of healthcare needs of the people the way Germany does. Because with 4 trillion for 7 million people, you can never afford the same with 1.4 billion people with half that GDP. That means that we have to disabuse ourselves of the fact that we can actually send money or pour money at the problem. We have to start thinking about producing health production. Starting to think that our budget for health have to include how many people have clean water, how many people have adequate sanitation, and how many people have nutrition, because that's where diseases come from. Number 3 is about then asking ourselves, what regulations and policies do we need to pass through our parliament to ensure that people are having healthy foods, not just by their choice, but by protecting them, because they will not always know what is healthy and what is not. What is the role of food labeling to say this food is unhealthy? We did that with cigarettes. We've done it with alcohol. Why can't we do it with sugar? Why can't we do it with other fast food that people are consuming? So that you make a choice to buy your child a certain food, you know you're making an unhealthy choice. But now without labeling, without front or back labeling, you'll never know. And that's why we are having rising diseases of what we call non-communicable. Hypertension, diabetes, obesity. 50% of all our admissions have to do with these diseases. Not HIV, not TB, not malaria. They have to do with cancer, diabetes, and hypertension, which we can prevent through regulation of food and also enabling people to live healthy lives by having security on the path that people can walk at night instead of having to take matatus to go home. If we provide security and street lighting, people can walk. And as I said, if you walk 7,000 steps a day, you reduce your risk of death by 50%. Let us focus on producing health, not treating disease. Now, on one side, I'm saying that let us focus on building health, but we will have people who need medication. That's inevitable in every community. But then you must have data. That data must lead you to decide, in this particular community, the medication that we are likely to need are for malaria, because you're in a malaria endemic area. But in this other community, the medication you need is for hypertension, because these people are more likely to have hypertension. That decision and that data is what will make you decide what to buy and what to stop, community by community. It's precision public health. You must decide based on the community and their disease patterns what to purchase. But if you have centralized, supply-driven purchases, not demand-driven, then you end up with a mismatch, whereas what you procure may not be what is needed for the particular population. And that then means that you may procure what's not needed, and because drugs are expiring, they're going to expire. And the ones that you needed, because you didn't use data, may run out because the demand for them is higher than what you purchased because of a mismatch between supply and demand. That's what we need to do.